Welcome to Chapter 4. In this chapter, we're going to talk about autonomic drugs. But before we can do that and talk about the effects of the autonomic nervous system, we have to do some basic nervous system review. First, you have the CNS, the central nervous system, your brain and your spinal cord, which moves out to the peripheral nervous system, and that has two parts, the autonomic and the somatic system. The somatic is the system that we can control with voluntary muscle movement. The autonomic nervous system functions as an automatic system for many body parts. It regulates things like blood pressure, heart rate, GI motility, salivary gland secretions, and bronchial smooth muscles. The autonomic nervous system relies on specific neurotransmitters and a variety of receptors to get the responses in the target tissues. So on the sympathetic side, the neurotransmitters are primarily epinephrine and norepinephrine. And on the parasympathetic side, the receptors or the neurotransmitter is acetylcholine or nicotine. So this is just a little cartoon of the somatic nervous system. These are the muscles that we have control over. Throw a ball, run down the street. This is not what we're talking about today. Today we're talking about the autonomic nervous system, and that has two divisions, the sympathetic autonomic nervous system and the parasympathetic part of the autonomic nervous system. These two divisions often have opposite effects. I think of them like yin and yang. Almost all body tissues are innervated by the autonomic nervous systems, and most parts have both sympathetic and parasympathetic innervation. With this dual innervation, the sensory fibers in one division can influence the fibers in the other, meaning that there's communication between these two systems. So, some reasons why you should become familiar with the autonomic nervous system. Well, it's part of the class, so we'll have some testing on it. Certain autonomic drugs are used in dentistry. For example, vasoconstrictors can be added to local anesthetics to keep them more locally acting, or they can be used to increase or decrease salivary flow. A lot of drugs we'll talk about anticholinergic side effects, and the big one that you guys are concerned with is dry mouth or xerostomia. And we'll especially talk about this when we go into other drug classes such as antidepressants or antipsychotics. So neurotransmitters, both the parasympathetic and the sympathetic divisions of the autonomic nervous system, as I said, tend to act in opposite directions. For example, the parasympathetic nervous system is concerned with digesting a yummy meal and chilling out. The opposite is true of the sympathetic nervous system. It's designed to kind of get you ready for emergencies. Think fight or flight. I've got a tiger running after me, and I need my heart to pump fast, my lungs to expand, so I can outrun him. So my body doesn't really need to work on digesting that yummy meal, or maybe I might become the meal. So, question, what are the two divisions of the autonomic nervous system? C and E. Here's another example of the opposite responses in the eye, where the sympathetic system will cause dilation of pupils. Hey, I need to get more light in because I need to find out where that tiger is. And the parasympathetic system will produce more of a pinpoint pupil or miosis. Okay, autonomic nervous system drug types. There's 4 types of drugs that we're going to talk about in this chapter. Not all of them are actually used in practice. So a drug that stimulates the parasympathetic system is called a cholinergic or a parasympathomimetic. A drug that blocks the parasympathetic system is called an anticholinergic or a parasympatholytic or a cholinergic blocker. A drug that stimulates the sympathetic nervous system is called a sympathomimetic, or you could use the word adrenergic. Or a drug that blocks the sympathetic nervous system is called an adrenergic blocker, or a sympathetic blocker, or a sympatholytic. A sympathomimetic amps you up, and a sympatholytic cools your jets. Kind of like think of about it like a beta blocker. So what are some uses for sympathomimetic or adrenergic medications? They can be used for their cardiac effects. They can be used for their effects on the lungs. They can be used for treatment of anaphylaxis, and they can be used as CNS stimulants. So quick question, adrenergic nerve cells make what neurotransmitter? C, norepinephrine. So adrenergic receptors are found in most tissues of the body, and there's two types of receptors, alpha and beta. Alpha receptors are divided into two categories, but we're going to gloss over this a bit as there aren't very many popular drugs that affect the alpha-2. Activation of alpha receptors by sympathomimetic drugs produce a response that includes vasoconstriction. Beta receptors are divided into actually three categories. We're going to discuss two of them. Beta-1 receptors have cardiac stimulation that increases the heart rate and increases the contraction strength. Beta-2 gives you bronchodilation, your lungs expand, and vasodilation so you can get more oxygen to your tissues. So more specifically, let's talk about alpha-1. Alpha-1 causes smooth muscle contraction or vasoconstriction. So I have this little picture of a fish that's kind of shaped like the Greek letter alpha, and if you pulled on the ends of the little fish, you'd see that the hole in the middle gets smaller or constricts. So some effects of this, constriction of blood vessels, makes it harder for you to poop or pee. In the uterus, it helps you push that baby out. It makes your hair stand on end. It can constrict lungs, and it can dilate your pupils. Now, dilation, you think, well, that's making it bigger, but it's dilating by constricting the muscles around your pupils. So sometimes agents with an alpha effect can be added to a local anesthetic to prolong the action of the anesthetic, and that might reduce the potential for systemic toxicity. Epinephrine can be applied topically around a bleeding area to stop bleeding, and other sympathomimetic agents are often made into nose drops or sprays to treat nasal congestion. And so these can provide a symptomatic relief by constricting the vessels and reducing the swelling of the mucous membrane in the nose. Alpha blockers can be used, a disease called BPH, benign prostatic hypertrophy. This can affect men that have an enlarged prostate. Their symptoms are they have a difficulty starting a urine stream or weak flow. Sometimes they feel like their bladder is not completely empty, or they have an urge to urinate soon after they've just gone to the bathroom. So some examples of alpha blockers are doxazocin, Cardura, prazosin, Minipress, terazosin, Hytrin, and tamsulosin, Flomax. So some of these can be used for the treatment of BPH or hypertension. So side effects of alpha blockers, primarily I'm worried about orthostatic hypotension. And remember, this is going to be true for all medications that treat hypertension. So what happens is you have these big, your vessels are bigger, and let's say you're laying down, relaxing, and the phone rings, and you stand up, and those vessels that are bigger allow the blood to fall down to your lower extremities and not to your brain, making you feel a little bit dizzy. Quick question, what is not effect of the sympathetic nervous system? B, speeding up blood to the digestive system. Okay, let's talk about beta receptors. Beta receptors are found in the heart, and you have one heart, or beta-1. Beta-1 agonists make the heartbeat faster, which is a chronotropic effect, and harder, or more forcefully, which is an inotropic effect. Beta-2 receptors are found in the lungs, in the vascular bed, and in the uterus. Think you have two lungs. The beta-2 receptors, when they're stimulated, they produce bronchodilation and vasodilation. And so drugs that have this effect are used in treatment of asthma. So beta-1 receptors increase the heart rate, increase the contractility of the heart, increase cardiac output, and renin in the kidneys. Beta-2 expands the lungs. Think about the lungs being kind of shaped like a butterfly. So for beta blockers, a beta blocker basically blocks that beta receptor site. There are a lot of beta blockers. These are commonly used, and the generic names often end in OL. So they're easy to recognize if you're looking at the generic name. Because beta stimulation produces vasodilation, bronchodilation, and tachycardia, a beta blocker would block or do the opposite. So a beta blocker produces bradycardia, or a slower heart rate. And in asthma patients, these drugs can make it harder for a patient to breathe. So beta blockers can either be non-specific or non-selective, such as propranolol or Inderal, or beta blockers may be specific or selective, such as atenolol or tenormin. Specific beta blockers have more activity on the heart and blood vessels than on the lungs, and therefore produce fewer side effects. So side effects of beta blockers: dizziness is another way of saying orthostatic hypotension. Also, if a patient is diabetic and hypoglycemia occurs, these beta blockers are going to stop them from getting those feelings of, well, my blood sugar's too low. Also, beta blockers are not good to use in patients that have asthma because it hurts their ability to breathe. So some common beta blockers, propranolol was Inderal. Sometimes propranolol is used for the prophylaxis of headaches. So that's a different indication than you have with some other beta blockers. Atenolol is tenormin, bisoprolol is Z-beta, metoprolol, sometimes people will pronounce it metoprolol, either way is fine. The brands are Lopressor and Toprol. Nadolol is Corgard. And then some beta blockers actually have some alpha blocking activity too, and that's Carvedilol or Coreg, or labetalol, and the brands were Normidine and Trandate. So beta blockers block the effect of what? C. Okay, switching gears, we're talking about the parasympathetic nervous system, and then we're going to talk a little bit about the uses of cholinergic medications. They can be used in ophthalmic drops, like pilocarpine can be used to treat glaucoma. Pilocarpine can also be used in a tablet form to treat dry mouth. Sometimes these agents are used to diagnose and treat MS, myasthenia gravis. That's a chronic disorder that causes muscle weakness. It's an autoimmune disease where antibodies bind to the cholinergic sites and prevent acetylcholine from triggering muscle contractions. So adverse reactions related to cholinergic drugs are essentially an extension of their pharmacologic effects. And this is something I want you to memorize. Cholinergic medications, their actions: salivation, lacrimation, urination, and defecation. So if you're a cholinergic agonist, your mouth waters, your eyes tear up, you can pee, and you can poop. So here are some contraindications or cautions to use for cholinergic agonists. They can cause bronchospasm or precipitate an asthma attack. So these aren't good drugs to use in asthmatics. Also, you have to be careful with patients with hyperthyroidism because it can increase their risk of AFib. If either the GI or the urinary tract system is obstructed, and you give them a cholinergic agent, the increase in secretions and motility could cause pressure, and the system could back up. So not a good idea there. They can cause reflex tachycardia, and that can result in making cardiac conditions worse. And also, patients with peptic ulcers shouldn't be given a cholinergic agent because the agent could make the ulcer worse. So, because the cholinergic agents are increasing the gastric secretions and gastric motility. So, the anticholinergic uses. Why do we use anticholinergics? There actually aren't very many popular drugs in this class. They can be used as drying agents in dentistry or in surgery. They can relax the smooth muscle in the lungs. Be used to treat Parkinson's disease or motion sickness. Has anybody been on a cruise and used scopolamine or transderm scope for motion sickness? And anticholinergics can be spasmolytic agents, and so they can reduce the spasms and smooth muscles in the gut. So there's an example up there called dicyclamine or Bentyl is that drug. And that's actually used every once in a while. So parasympathetic contraindications of anticholinergics. That's a mouthful. Okay, so here's some patients where you shouldn't be using anticholinergic agents. Patients with glaucoma, because they can have a rise in intraocular pressure in their eye. Anticholinergic agents can make urinary retention worse. So if you have a man with benign prostatic hypertrophy or BPA, they already have difficulty in urination, and giving these drugs will make it worse. If a patient's constipated, these will make it worse. And an anticholinergic agent has the ability to block the vagus nerve. So again, with patients with cardiovascular disease, you worry about causing trouble. So adverse reactions of anticholinergics, remember that SLUD, so dry eyes, dry mouth, you can't pee, can't poop. And lastly, we're going to talk about the parasympathetic nervous system nicotinic agents. So nicotine found in cigarettes, increases your blood pressure, heart rate, GI motility. A lot of people are trying to stop smoking, and they might use a nicotine replacement, which is just basically binds to the same receptor site, or they can use a product called varenicline, and the brand name is Chantix, and that's a partial receptor agonist. That drug stimulates the nicotine receptors more weakly than nicotine itself, and so it reduces the cravings and decreases the pleasure of cigarettes, and so it helps people stop smoking. I have had patients tell me that it makes them extremely irritable. So with that, I'm going to do a little review, and see you in class on Wednesday.
About adrenergic agonists. So let's get right into it. Adrenergic agonists are a large group of drugs that mimic the actions of norepinephrine and epinephrine, which naturally occur in our bodies. Norepinephrine is also known as noradrenaline, and epinephrine is also known as adrenaline. Now, collectively, the agents that activate adrenergic receptors are called sympathomimetics, and the agents that block the activation of adrenergic receptors are called sympatholytics. And let's start with alpha receptors. Alpha receptors can be divided into two main groups, that is alpha 1 and alpha 2. These can be further subdivided into alpha 1a, alpha 1b, alpha 1c, etc. But for simplicity, let's just focus on alpha 1 and alpha 2. Now, alpha 1 receptors are mainly located on vascular smooth muscle throughout the whole body, and when activated, they lead to vasoconstriction. They are also located on the dilator muscle of the iris, and when activated, they lead to mydriasis, which is dilation of pupil. They are also located on urinary sphincters, and when activated, they lead to contraction and urinary retention. Alpha 1 receptors are also located in the liver, and when activated there, they lead to glycogenolysis, which is breakdown of glycogen to glucose. Lastly, alpha 1 receptors are also found in the kidney, and when activated there, lead to inhibition of renin release. And as a reminder, renin is an enzyme that is secreted by the kidney and is involved in the regulation of blood pressure. So in summary, activation of alpha 1 receptors leads to sympathetic response. Just think about it. When you are in a fight or flight mode, It's advantageous to have constricted blood vessels in case you start bleeding. You also want to retain urine when you're fighting or running away. And you definitely need extra glucose. Now, what about alpha 2 receptors? They are primarily located on Additionally, alpha 2 receptors can be found on the pancreatic islets, and when activated, they lead to decrease in insulin secretion. Now, let's move on to beta receptors. Beta receptors can be divided into three groups, that is beta 1, beta 2, and beta 3. Unlike alpha receptors, beta receptors are coupled with GS protein. Now, let's start with beta 1 receptors. Beta 1 receptors are mainly located on the heart, and when activated, they lead to increased heart rate, increased cardiac contractility, and increased AV node conduction. Beta 1 receptors are also located on the juxtaglomerular cells in the kidney, and when activated there, they lead to increased renin release, which results in increase in blood pressure. Now, let's move on to beta 2 receptors. Beta 2 receptors are mainly located in the lungs on the bronchial smooth muscle, and when activated, they lead to bronchodilation. They are also located on the vascular smooth muscle and the arteries of skeletal muscle, and when activated, they lead to relaxation of blood vessel, or in other words, vasodilation. They are also located on smooth muscle in the GI tract and uterus, and when activated there, they lead to smooth muscle relaxation, which in GI results in decreased motility, and in the uterus, it can cause inhibition of labor. Lastly, beta 2 receptors can be found in pancreas, and when activated there, they lead to increase in insulin secretion. And now, before we move on, let's not forget about beta 3 receptors. Beta 3 receptors are mainly located in adipose tissue, and when activated, they lead to increase in lipolysis, or simply breakdown of stored fat. Beta 3 receptors can also be found in the urinary bladder, and their activation there is thought to cause relaxation of the bladder and prevention of urination. In this lecture, I'm going to talk about adrenergic antagonists. So let's get right into it. Adrenergic antagonists, also called sympatholytics, bind to adrenergic receptors, but instead of stimulating them, they actually prevent their activation. And just like with adrenergic agonists, we can divide antagonists based on their affinity for alpha or beta receptors. So we can divide adrenergic antagonists into two main groups, that is alpha blockers and beta blockers. So let's start with alpha blockers first. Alpha 1 adrenergic antagonists block the binding of norepinephrine to the smooth muscle receptors, which results in vasodilation and thus lowering of blood pressure. This is why alpha blockers are useful in the treatment of hypertension. Now, alpha blockers can be subdivided into two groups, that is, non-selective alpha blockers and selective alpha blockers. As you might have guessed, non-selective agents can block both alpha 1 and alpha 2 receptors. Examples of these are phentolamine and phenoxybenzamine, which are used in the treatment of hypertension, specifically caused by pheochromocytoma, which is a tumor of the adrenal glands that secretes norepinephrine and epinephrine. Now, let's move on to selective alpha blockers, and let's discuss alpha 1 blockers first. So these agents selectively and reversibly block alpha 1 receptors located mainly in vascular smooth muscle, which reduces peripheral resistance and leads to decreasing blood pressure, and they also block receptors in the smooth muscle of the bladder neck and prostate gland, which causes smooth muscle there to relax, leading to relief of the urinary difficulties associated with benign prostatic hypertrophy, BPH for short, or simply enlarged prostate. Now, examples of alpha 1 selective blockers include prazosin, doxazosin, terazosin, tamsulosin, alfuzosin, and silodosin. And note that this ending with osin is a pretty good giveaway when it comes to identifying alpha-1 blocker. Now, the first three of these, that is prazosin, doxazosin, and terazosin, are effective treatment for hypertension, but have lesser effects on relieving symptoms of enlarged prostate. On the other hand, tamsulosin, alfuzosin, and silodosin have little effect on blood pressure, but are much more effective for relieving symptoms associated with enlarged prostate. And this is because these agents have increased selectivity for alpha-1 receptors in the prostate, specifically alpha-1A subtype. Now, when it comes to side effects, orthostatic hypotension is one of the main concerns when initiating alpha-1 blocker, although it's not as severe as that observed with non-selective alpha blockers. Additionally, vasodilation produced by alpha-1 blockers can lead to headaches and nasal congestion. Finally, what about alpha-2 selective blockers? Well, alpha-2 selective blockers have very limited clinical application in humans, and they are used mainly in research. Beta blockers are useful in the treatment of hypertension, heart failure, heart attacks, angina, and cardiac arrhythmias. Additional uses include treatment of glaucoma and migraine prophylaxis. So now let's start by discussing first-generation beta blockers, which also happen to be non-selective. That is, they block beta-1 and beta-2 receptors throughout the body. Examples of these agents include propranolol, pindolol, nadolol, sotalol, and timolol. Now, practically, all of the applications of these agents are based on blockade of beta-1 receptors on the heart, which results in decreased heart rate, delayed conduction through AV node, and reduced contractility. So now, the final outcome is decreased cardiac output and decreased oxygen demand of heart muscle. Besides being useful in treatment of hypertension, angina, and arrhythmia, note that propranolol, due to its lipophilicity, can also penetrate into the CNS and was found to be effective for migraine prophylaxis. On the other hand, timolol, when applied topically to the eye, was found to decrease intraocular pressure, which is why it is often used for treatment of glaucoma. However, all that being said, let's not forget about blockade of beta-2 receptors by these non-selective agents. And as you may recall, beta-2 receptors are predominant in lungs, so their blockade can actually lead to bronchoconstriction. For this reason, these non-selective beta blockers are not recommended in patients with COPD or asthma. Now let's move on to the second generation beta blockers, which happen to be selective for beta-1 receptors. And because of that, we also call them cardioselective beta blockers. Now, this cardioselectivity makes these agents more suitable in patients with chronic lung disease. However, keep in mind that at high enough doses, this beta-1 selectivity can be lost, and beta-2 receptor blockade may occur. Examples of these agents include atenolol, acebutolol, bisoprolol, esmolol, and metoprolol. Now, let's move on to the third generation beta blockers. And here you need to pay special attention because things can get a lot tricky. So, unlike the first generation group that included non-selective agents, and unlike the second generation group that included selective agents, the third generation group includes both non-selective and selective beta blockers. However, what makes the third generation beta blockers different from the other two is that they also act on blood vessels to cause vasodilation. So here we have non-selective agents such as carvedilol and labetalol, which produce peripheral vasodilation by blocking not only beta but also alpha-1 receptors. And on the other hand, we have beta-1 selective agents such as nebivolol, which produce vasodilation by inducing the release of nitric oxide from endothelial cells, and betaxolol, which is thought to produce vasodilation by additionally blocking calcium channels. the side effects associated with cholinergic agonists. Now, the adverse effects that can result from use of these agents are due to overstimulation of cholinergic receptors, and they are as follows: diarrhea, urination, meiosis and muscle weakness, bronchorrhea, bradycardia, emesis, lacrimation, and salivation. Now, how can you remember all of these? Well, the great mnemonic is right in front of you. Dumbbells. It's all you need to know to remember the common side effects associated with cholinergic agonists.